We have around 70 participants now. I think more than 70 participants. I think we are good to go.
Yeah.
Thank you very much, everybody. So, shall I start? Yes.
First of all, I would like to introduce you, Sampath. Yeah. So actually, this is our. I would like to welcome all the participants today. There are around 70 participants, so I'm very happy about that. And on behalf of the Palliative Care and End of Life Care Task Force of the SLMA, and this is our third webinar, and we are conducting a webinar series almost every month, or we are going to frequently do it at least every 2 weeks from next week onwards. So today our speaker is, I would like to introduce you. He's associate professor of he is a clinical associate professor of internal medicine, Faculty of Health and Medical Sciences, the University of Western Australia, as well as he is a consultant physician and a consultant palliative care physician of the Palliative Care Service, Charles Gardner Osborne Park Health Care Group in Western Australia. And more than that, for us, he is a good friend, colleague, as well as he had been a resource person several times. Physically, he came here for several conferences as a resource person in symposia, as well as training of trainer programs organized by the Asia Pacific Palliative Care Hospice Network. So he was one of the important and a respectable resource person of APHN training programs as well. So I would like to invite Professor Sampath Kondasinghe, MBBS Sri Lanka, Colombo University graduate, FRCP, as well as FACHPM, to talk on practical management of gastrointestinal symptoms in palliative care today.
Thank you very much, everybody. Thank you for coming in, and thank you for inviting Dr. Ramdasa as well as Dr. Andhani Kumara. So this talk, it's going to be a very short and sweet one, I suppose. This is going to be only 20 slides. We can go through them, but this probably is adjunct to what Dr. Ramdas's group or Dr. Andhani Kumara's group did with the SLMC a few years ago as a guideline book. They have published, if anyone is not familiar with that, they have published the palliative care, the guidelines or prescription guidelines a few years ago, I suppose, that has a gastrointestinal management chapter. So anyone who is not familiar with that, contact probably the Dr. Andhani Kumara's group, so they will be able to show where that resource is. So let's go step by step. So this talk probably go for 30 to 40 minutes. What I'm going to cover here is some gastrointestinal symptoms which we see in the palliative care setting. Why do I talk about the gastrointestinal symptoms? Why a gastroenterologist is not coming here? I suppose this is a good way to talk about it. Most of our patients, their gastrointestinal symptoms are not related to gastrointestinal tract pathology. So that is one reason why the palliative care physician is talking about it, rather not the gastroenterologist. So when we talk about non-palliative care pathologies, you can clearly identify a pathology if a patient vomiting, if a patient coming into your clinic and vomiting with gastroenteritis, bowel obstruction, you know where to refer or what advice you are getting from a gastroenterologist. But unfortunately, palliative care patients symptoms, any of these symptoms which I have listed here, may not necessarily come from gastrointestinal tract. That's why probably I'm talking about it rather than a gastroenterologist. So during this talk, I'm going to talk about nausea and somewhat touch base about vomiting. And I will talk about constipation management, and I will talk about appetite management. Um, and we will briefly talk about how to manage hiccups in palliative care. At least 1/3 of the talk is going to be about nausea and vomiting management. Um, so nausea and vomiting, what is your default way of treating it? Patient comes into your clinic, patient comes into your, you see in the hospital ward round, you probably just write a nausea medication. Okay. Is that how random it is? How random it should be? Probably not. As I suppose this crowd is everybody is a doctor, so why do we need to just write medication just because they are available, or do we have to think about what we are prescribing? To give an example, every patient we see in palliative care who come with nausea and vomiting does not have a gastrointestinal pathology, as I mentioned. So some of these medications we prescribe in this list, they are targeting only gastrointestinal tract. Okay, let's go in detail. It shouldn't be a random prescribing like this. So I tell all my medical students and registrars, if you are prescribing just because everybody is prescribing Maxalone, we shouldn't prescribe that. Just because the palliative care doctors or Dr. Ramadas is prescribing haloperidol more, you shouldn't prescribe that. Or when you are in ED, it's easy to give ondansetron, you can give ondansetron. That is not the way you should prescribe our patients on anti-nausea medications. Let's think about a bit more logical way to prescribe anti-nausea medications. Where should we start? What matters most is your patient nausea history. I'm going to start with one example. You go and see the patient in your ward round, or you see the patient first thing in the clinic. Then patient says, "Oh, I was vomiting from the morning." What does that even mean? If it doesn't take long time to get this simple history. So if you identify where the nausea is coming from, or you have some idea where the nausea can be caused, then you can have a target history. It doesn't need a 30-minute history. It will take probably 1 minute to take this history effectively. So your patient who is vomiting in the first thing in the morning, what I would ask is, if this patient is vomiting while patient is in sleeping position, or patient started vomiting sitting up once he sat up on the bed. Second question I ask, is this patient vomiting soon after having a first sip of fluid or food in the mouth? Or is this person started vomiting soon after they started smelling the family cooking in the kitchen? So those are some simple questions you can ask. I will tell you why that matters. So to tell you why that matters, you probably in your mind, you can have this simple diagram tells you, don't go in detail about any of this wording, just see four body organs. If you take home this message, this simple message from this talk, that will be more than enough for me. Basically, there are four organs I consider any patient describing nausea to me. So those four organs are your GI tract, that is here down here, GI tract. Second organ is in your midbrain, it's called chemoreceptor trigger zone. And third organ is your vestibular system in the ear. And the fourth organ is your brain itself, brain cortex. Every time patient describes to me, I'm vomiting, my brain works which or out of these four organs give this patient nausea. Those are the major four organs which can make feel nauseous. Okay, we will go with examples. We will go back to the 4 questions or 3-4 questions I asked before. If the patient says, I was fine when I was sleeping, and minute I sat up on the bed, I feel nauseous, that is most likely culprit is your vestibular system. Similar to motion sickness, your vestibular system changes your position and people feel nauseous. Okay, if the patient says, doctor, I was all right when I was sitting up, but soon after my wife brought some food and put in the mouth, and I felt nauseous, felt like everything coming out. So probably that time the nausea is coming from your gastrointestinal tract because the food is not processing, it's pushing it out. Okay. The third one is if the patient woke up with the smell of food cooking in the kitchen and feeling nauseous, most likely organ culprit is your brain cortex. They feel that smell, nerves get stimulated, they become nauseous. So that explains some of the symptoms, but I will go to the fourth organ bit later. Okay, which is the chemoreceptor trigger zone. So to tell you my background a bit, these days I do not see a lot of palliative care patients. My majority of the work is I'm the lead clinician in the renal palliative care service. So I'm looking after the patients who has end-stage kidney disease, who are having symptoms. Most of them, half of them are patients who are not going through dialysis. Other half probably patients who are on dialysis and having symptoms. So why I told my background about it, in those patients, dialysis patients, probably any of you have seen kidney failure patients. They are one of the group of patients who are extremely nauseous. Those patients, why do they get nauseous? They get nauseous most likely related to their urea level going up. When the urea level go up, which one of these organs sense it? That organ which we missed, that is the chemoreceptor trigger zone. So if you have an organ failure patient, someone who has kidney failure, that chemicals, unnecessary chemicals circulating in your body, this organ, what we call chemoreceptor trigger zone, sense it. If your patient's having liver failure, chemoreceptor trigger zone sense all that bilirubin. If you have chemotherapy, cancer patients, that is the organ which sends the nausea. So they basically, that's a protective response. Body forms, the people feel, oh, there is an unnecessary chemical circulating in my body. So let's get it out. Let's vomit. So that's a protective response. This chemoreceptor trigger zone is forming. So that is the fourth organ. So I suppose the audience is a bit more clear. So if people's vestibular system gets stimulated, similar to what they get in the motion sickness, that is this organ, vestibular system, and then the second organ is chemoreceptor trigger zone, when the unnecessary chemicals circulating in the body, like chemotherapy or even medication which we first introduce. Sometimes it could be opioids you introduce, patients start vomiting. That's chemoreceptor trigger zone. Or unnecessary chemicals made by your own body, urea, bilirubin, all those chemicals. The other organs like gastrointestinal tract, that usually shows the expulsion of food when you ingest food and you get this nausea, most likely associated with vomiting. Okay, so now you can read about the writing. Just let's focus on the writing, which is in the lowermost line, which is in green. So the medications we spoke before, they all don't work in every area. Okay. So for example, metoclopramide or maxolone predominantly work on your gut. That's to move the gut. Haloperidol and olanzapine, they work in the chemoreceptor trigger zone. Domperidone again work in the gut. So ondansetron, chemoreceptor trigger zone. So we target each organ area differently. For example, if oncologists are giving chemotherapy, you are the doctor who's looking after in the primary care setting. If patient comes and tells you after chemotherapy I get nauseous, yes, by all means, ondansetron is a good medication because it works in the chemoreceptor trigger zone. So cetrons are strong medications in the chemoreceptor trigger zone. At the same time, if your patient comes and tells you you have liver failure, I'm having dialysis, the day before the dialysis, I'm really become nauseous, the medications will be in the, again, chemoreceptor trigger zone area. Something probably what we will use is a medication like haloperidol, just to address that chemoreceptor trigger zone. Why don't we like ondansetron as much as other doctors? Palliative care patients inherently run the risk of constipation because of the opioid medications, because of their sedentary lifestyle. So every time we add a cetron, 5-HT medication, you constipate them. So please think about constipation before adding ondansetron into your patients. I know this is an easy medication. They go under your tongue. That's easily absorbed. That's an easy fix. But patients get constipated. Unfortunately, systems like Australia, we are not allowed to prescribe ondansetron for any patients outside chemotherapy or radiotherapy patients. So there are restrictions around it. So you have your medications like haloperidol when you need to prescribe a medication for chemoreceptor trigger zone. For example, if your patient is liver failure or renal failure, go for haloperidol. What doses do you prescribe? They're all written in your guidebook from the SNMC. The doses you prescribe are, remember this fact, they are not the doses which you prescribe in psychiatry patients. Okay, psychiatry patients, therefore psychotic symptoms, the haloperidol doses are quite massive. Okay, so to address chemoreceptor trigger zone, doses you prescribe are 0.5 milligram. Okay, 0.5 milligram twice a day probably is your starting dose. If the haloperidol is not working with the 3 to 4 milligrams a day, it's not going to work. So that is way below the doses which psychiatrist prescribes for psychosis. So the risk of sedation with these kind of haloperidol doses are less compared to psychiatric doses. Please do not go and prescribe doses like 5 milligram twice a day of haloperidol. That those doses are not necessary for nausea management. 0.5 milligram twice a day is very good enough. Along that line, there is another medication I like to introduce. That's a common medication used by psychiatrists, and more oncologists and a lot of physicians start using this medication for the purpose of nausea control. And it's proven to be one of the most effective nausea medications. That medication is olanzapine. Probably that was one of the commonest medications I use these days for nausea related to chemoreceptor trigger zone in my renal failure population. So olanzapine doses like 2.5 milligram night time or 2.5 milligram twice a day is a very good dose for nausea control. So again, they are not as high as what the psychiatrists use. They are very good medications for nausea management. In fact, it is proven to be effective in patients who are not in chemotherapy patients who are not responding to ondansetron. So this is another, if we have palliative care medical officers here in the audience, yes, definitely olanzapine is another choice you can use. It comes in the under the tongue preparation, I suppose, in Sri Lanka as well. So it's a good choice if people are profusely vomiting. So you can use the under the tongue preparation, olanzapine 2.5 milligram twice a day. I use up to 10 milligram a day, 10 milligram total dose a day if you want to control the nausea. So that's probably what I address as chemoreceptor trigger zone. The next organ I desperately want to address is the zone of the gastroenterologist. So gastroenterologists will tell you the GI tract. So probably we all think all the nausea and vomiting are related to GI tract. By now, the audience probably know it is not related to GI tract. For example, in renal failure patient or liver failure patient, nothing to do with GI tract, it's chemoreceptor trigger zone. Okay, so GI tract, how do they get nausea? So if your patient has diabetes and this patient's gastric emptying is slowed, that's probably related to GI tract related nausea. Or at the same time, if your patient has a gastric cancer, if your patient has a bowel cancer, if your patient is having radiotherapy to the gut, if your patient has a massive liver mass blocking the gut, expanding on the gut, or if there are a lot of lymph nodes, if your patient has got ascites in the tummy. So all these causes are what I consider as GI tract related nausea. Okay, so these patients, how should I deal with them? What we should do is, if this is related to ascites or some mass, the gastric tract is getting slowed and you want to push the gastric tract, what you should do is we should introduce a medication called medication to push the gut in the right way. Those are called prokinetics. So this is written here, prokinetics first line. So prokinetics are the medications which pushes the gut in the right direction. Common medications we use default is domperidone and metoclopramide. I'm suppose everyone in this audience, I don't need to describe domperidone and metoclopramide to this audience. Both medications push the gut in the right direction. So if you're thinking this is gut slowing related nausea, by all means use those medications. The trouble with domperidone, obviously there is no injectable formulation. You swallow the tablet, next minute patient vomits. There's no way to absorb. So in that point, there's no point prescribing domperidone to a patient who is profusely vomiting because there's no time to absorb it. So in that case, you probably need metoclopramide to push the gut in an injectable form. So what other medications we use? So what happens if they are describing some motion sickness, or patient describe every time I stand up, every time I sit up, my head spins. I feel like vomiting. So those are classic vestibular symptoms. Um, how do I address vestibular symptoms? Commonest medication is Stemetil. Probably everybody knows Stemetil. So Stemetil works in the vestibular system. Phenergan works in vestibular system. So those medications are good in that vestibular kind of nausea. How do they get nausea in the vestibular system related problems? If they have deposits in the ear, so in the skull, cancer patients, or the commonest other way of getting vestibular nausea is in the patients who actually lose the weight. Okay, so when patients lose weight, what happens is their vestibular system get confused. So their bodies for 40 or 50 years got used to the same weight. Suddenly they lose weight and vestibular system get confused that, oh, my body weight, my balance is gone. So people, every time they move, they get nauseous. So those patients, Stemetil might be a good choice. Why did I use the might be word? Stemetil is a medication which works and develop resistance pretty soon. So your patient will describe, doctor, first week Stemetil worked, now I'm even more nauseous. Okay, so Stemetil is a cautious use of medication. If you are using Stemetil for these patients, please have a treatment break every few days at least, because these patients will develop resistance to Stemetil pretty soon. So that's probably a take-home message. In summary, you need to remember 4 organs. So metoclopramide,
Yeah, you can see the
my pictures have misaligned. So metoclopramide works in the GI tract, and then promethazine works in the vestibular system. Haloperidol, olanzapine, and the cetrons work in the chemoreceptor trigger zone, and all the other medications. So dexamethasone, lorazepam, even medications. The last medication is obviously in the hands of oncologists. Medications like apropitant, normal doctors won't prescribe those. They are chemotherapy related medications. If you use any of those medications, they are working in the brain itself, brain cortex itself. So after this talk, please do not go and prescribe lorazepam for every single patient who has nausea. So I'm telling, do not prescribe lorazepam for every patient of nausea, having nausea. It's a very exceptional medication, or a benzodiazepine should be only used in this particular condition called anticipatory nausea. So you probably see even the day before chemotherapy, patient is becoming nauseous. Or even before the day before some procedure, patient is becoming nauseous. Even before they think about the food, they become nauseous. So that's a brain-driven situation. That situation can be broken. That cycle, vicious cycle, can be broken with lorazepam or benzodiazepines. That's an exceptional situation. When should I use dexamethasone for nausea? It's again special situations. If the patient is having nausea related to increased intracranial pressure, then I will use a dexamethasone. So that's an exceptional situation. Now, this audience, just imagine going and start prescribing metoclopramide, haloperidol, and all those medications which I described. What happens then? They will come in few weeks' time. They will tell you, oh, doctor, I'm getting so rigid. I'm getting actually becoming tremulous. What is happening? Patients, most of the nausea medications are dopaminergic antagonists. They actually cause Parkinson-like extrapyramidal side effects. So basically, they will get dystonia, akathisia, tardive dyskinesia, and Parkinsonism. So those patients, it's a very tricky medication, especially if you prescribe nausea medications to a Parkinson's patient. Do not prescribe any dopaminergic antagonist. Okay, you cannot prescribe metoclopramide or metoclopramide or haloperidol. Your choices remain medications like domperidone. I sometimes use atypical antipsychotics like olanzapine. Okay, be careful. I'm just going to touch base about an exceptional situation of nausea. That's bowel obstruction. I suppose this audience has at least few times seen patients who are bowel obstructed coming with difficult to manage nausea. If you are working in general practice setting or a hospital general setting or oncology setting, I'm pretty sure everybody has seen a bowel obstruction. Here, I'm particularly addressing this situation called malignant bowel obstruction. What it means is cancer-related bowel obstruction. If you have a patient coming with cancer-related bowel obstruction, of course, you are going to get the surgeon's opinion whether it is surgically correctable or not. And surgical correction should not be an academic exercise for surgeon to know there are the bowel meds or not. It's rather should be good discussion between you as the primary doctor telling this patient has inoperable bowel obstruction because patient's bowel is or abdomen is full of metastatic disease, or patient has full of the cancer. It cannot be corrected. So if you tell the surgeons this 90-year-old father will not end up dying on the table because they just open the bowel for obstruction. So rather, this person will have good symptom control in the ward and die 5 days later compared to patient dying on the theater with surgical pain the day after. Okay, so just it's your job to explain to the surgeons when you are referring to the surgeon about these bowel obstructions. So I address bowel obstruction related nausea, or bowel obstruction itself is a GI symptom. So what we call is bowel obstruction is one of the palliative care or oncological emergencies. So you get the surgeon's opinion. Surgeon tells you, oh, if the patient is completely obstruction in 3 places, we can't surgically manage. What should we do? So what that situation, we call it conservative management. In these patients, we decide one or the other. One way is this patient is this patient completely obstructed, or if this patient is incomplete obstruction. So that part you can explain, you can find in, if you put your stethoscope into patient's tummy, and if you can hear the bowel sounds, not the tinkling bowel sounds in the complete bowel obstruction, then you can tell, oh, this might be an incomplete obstruction. Yes, patient hasn't opened the bowel for 3 days, but still has bowel sound. In that incomplete bowel obstruction, what I would do is I would actually stimulate the bowel. Okay. How do I stimulate the bowel? I will give a dose of prokinetic medication. Okay, so prokinetic medication, what we will do is we will give a metoclopramide dose so that you push the gut in the right direction. What will happen if you give ondansetron to this incomplete bowel obstruction patient? You will slow the gut. You will actually obstruct this patient completely. Okay, so this is a critical learning point. Please do not offer ondansetron or any gut slowing medications to incomplete bowel obstruction, because they will go into complete bowel obstruction because of your medication. Okay. On the other hand, if you have complete bowel obstruction, which is the top one, complete bowel obstruction, which you see in your x-rays, extremely distended bowel loops and air fluid levels, and you can't hear the bowel sounds. In that patient, in fact, maybe the x-ray shows some kind of point where the obstruction is happening, or your CT shows that. What should we do? If you give a prokinetics to this patient, next minute patient is going to scream in pain because your gut is twisted and you are pushing it against the twisted point. And in fact, you have a very high risk of perforating the bowel. In those patients, you will use a medication which actually does not move the gut. That medication could be something like haloperidol, something like olanzapine, which doesn't move the gut. So I suppose this audience have some understanding about how to manage that bowel obstruction situation medically. So these are some of the medications. I will skip these slides for the time purposes. So erythromycin is a very strong prokinetic. Yes, this is the antibiotic erythromycin. So it's a very strong prokinetic medication. Please don't spread erythromycin for after this talk. So it's a very specialist medication we use in ICU setting to move the gut, or we fail all the other measures. And these other medication, octreotide, is again we use in complete bowel obstruction situation when the gut is extremely swollen, just to reduce that pain from swelling of the gut. Okay, I think the part about nausea, vomiting, that's the end of it. The next symptom I'm going to talk briefly is constipation. Constipation is Sankat, how long do I have?
Sanka, it is 1 hour lecture, isn't that so? So if we can give some time, if you can give some time to ask questions also.
Yeah.
So if you can finish by 12:05 or something, that would be great.
No problem. So
Yeah.
in about another 10 minutes time? Yeah.
Yes, in 10
Yeah.
minutes time.
That's good. Thank you, Dr. Lanka. So next symptom I'm briefly going to touch base is constipation. I think that's a very common symptom. You are very familiar. I think you are very familiar, but it's a very common symptom either as a general practitioner or a hospital doctor. You day to day day-to-day deal with. Is it a simple symptom? Yes, it's a simple symptom to describe. It's not sometimes a simple symptom to manage or simple symptom. Anyone who has constipation, had constipation in their life, they will know post-operatively, maybe during the pregnancy, they all know how bad that constipation affect everything else. So don't take it lightly in palliative care patients, because every other symptom, including pain management, as well as nausea management and psychological distress, everything get escalated if you are constipated. So please keep an eye on constipation. And on top of that, medications we use for pain management will automatically make people constipated. So please keep an eye on constipation. So there are probably briefly, I have categorized constipation medication into these 5 groups. Just take a minute to go through those 5 groups of medications. Among those medications, if I were to ask not to use a medication, not to use a medication in palliative care patients, that will be the bulk forming agents. So please do not use bulk forming agents on palliative care patients. Okay, so bulk forming medications like psyllium or any of the medications which can cause bulk, or they are good medications for us who are mobile, who can take good fluid intake. But if most of our patients do not have enough fluid intake, so these bulk forming medications, brand, husk, those medications will constipate the patients more. So they will make a basically concrete inside their gut, so which cannot be controlled or which cannot be reversed at all. So do not use bulk forming medications on palliative care patients. So that leaves you with probably 3 groups of medications: stimulants, osmotics, and surfactants. What are your default ones? Default ones are going to be stimulants. What it does is it stimulates the peristaltic movement in the gut. So your Senna or bisacodyl, they are your stimulant medications. What about osmotics? The osmotics, there is a particular use. I'm pretty sure every single patient in this, every single doctor in this audience have seen a liver failure patient, either related to alcohol or cirrhotic patients. Every cirrhotic patient should be on lactulose. Okay, every patient should be on lactulose, and not because they need to open the bowel, but because that is the way you absorb ammonia or excrete ammonia through your gut. Okay, so any patients who are coming with cirrhotic or hepatic encephalopathy, they should open their bowel 3 times a day. Okay, 3 times a day. My patients probably, or the hepatologist or gastroenterologist, all of them say it's a 3 times a day bare minimum. So I do not, how I sell lactulose to the patients is, it's basically, if you get constipated, your brain, the chemicals, the toxic chemicals get collected in the gut and get absorbed. So it's not as simple, but lactulose is the only way to absorb those hepatic failure chemicals and excrete it. But do not replace lactulose in liver failure patients with any other medications. I'm telling you, do not. So your strongest ever other medications do not work for liver failure patients. Liver failure patients need lactulose. Okay, so they will open the bowel, but without lactulose, your ammonia is not going to go away. So that's one medication. The last group, surfactants, or the dacusate or Sena, Coloxil, dacusate or Coloxil. Coloxil is it's a very weak medication by itself. So the individual prescriptions are going to be very weak. So they are not going to be very effective medications. My understanding is opioid receptor antagonist, which we use for opioid-related constipation. It's not available in Sri Lanka, so I'm not going to talk about them. These slides, I'm forwarding them to Sanka if needed, or I have forwarded them to Sanka. Let's touch base with other topics. Constipation prevention is the key rather than treating. Okay, I'm pretty sure this, when we say GI symptom management, at least some of the audience were very keen to hear about anorexia and weight loss management or cancer cachexia management. So that's a very, what we call, attractive topic without answers. Okay, all our patients, regardless of whether you are an oncologist or a general doctor, your patient's family will bring these patients to you asking, doctor, my mom is not eating well. Can you give something to stimulate the appetite? She's losing weight in front of my eyes. Can you give something to increase the appetite? Honest answer, any of the research in the world did not find effective medication yet. Okay, so what about using steroids? Yes, steroids, prescribing steroids sounds like a great idea, and people become a bit happy and feel like they are eating. But was there any meaningful weight gain? No, there were no meaningful weight gain. Actual, when there are real studies done, what they show was after certain time, it was fat pad increase as well as fluid retention caused the weight gain. Rather than, probably the family will be happy because they look fatter, they gain weight, but actually there is no muscle mass or any other weight gain. It's a fat pad increase related to dexamethasone and fluid retention. So that is the steroids place, but probably they get short-term mood benefits. So people feel happy when the patients feel happy, families feel happy. So but more, all the studies say there is no meaningful weight gain. Progestins, we have even some ongoing studies saying some of the progestins are useful for weight gain. Again, no real benefit. So are there medications to treat cancer cachexia? Probably not. What is the newest medication in the horizon? Everybody start using these days. It's mirtazapine. So it's a psychiatric medication, antidepressant. It's shown to be appetite stimulating. The doses of mirtazapine, which is 15 milligram. Usually I start with 15 milligram at night time, which is the psychiatric dose itself. People get sleep benefits, as well as appetite stimulation benefits. So that is sometimes a win-win, but again, there are no studies which showed a meaningful weight gain. So in that setting, there are no medications. What is the commonest one I use? I probably use mirtazapine more than other two. And because it's easily accessible, can use. I will tell you one trick dealing with mirtazapine. Mirtazapine is a funny medication. Its lowest dose is the highest sedation. So if your patient comes and tell you, you prescribe a 15 milligram tablet, patient is sleepy, do not halve the tablet. So 7.5 is very sedative. So mirtazapine is a funny tablet which works the opposite direction because antihistaminic properties are highest at the lowest doses. So mirtazapine, if your patient is sleepy, your way to improve the sleepiness, too sleepy, is increasing the dose. That's a bit of a practical issue. So last bit of the talk is how to manage hiccup. I do not know whether it's a real gastrointestinal symptom or not. I thought of including that because I suppose that's one of the most distressing symptoms. If the patient gets hiccups, patient can't sleep at night. Even the family can't sleep at night because they are hiccuping 24/7. That's one symptom families and patients or patients feel life is worthless living, because 24/7 hiccuping is not your way to manage, not your way to live. Just you can imagine one day of constant hiccup is good enough to depress basically for most of us. And constant hourly or every 10-minute hiccups are not going to be a fun thing to patient to go through. I had few or at least one patient during last 20 years who actually had suicidal intentions due to uncontrolled hiccups. So it's a very significant symptom. So regardless of whether it's a gastrointestinal or not, I have included in that topic. So I manage hiccups in two ways. Again, I think why people are getting hiccup. Most people get hiccup because there is irritation in the upper gastrointestinal tract or around the diaphragm due to cancer or liver related issues. So for example, most people get liver metastasis related to cancer touching on the diaphragm, or lung cancer touching on the diaphragm. Diaphragm gets stimulated, you keep hiccuping. So I have divided hiccup management strategies into two sides. First side, it says how to reduce the onset of, how to minimize or get rid of the hiccups. Or the second way is, if that strategy doesn't work, how do we reduce the severity? How to reduce the onset is probably most guidelines say first line for hiccups is antipsychotic medications. Usually things like chlorpromazine or haloperidol. They are the first line medications for hiccups. In most guidelines. What else does work for hiccups? There are some studies showing anticonvulsants like pregabalin or sodium valproate. Those medications, especially pregabalin gabapentin, which works in the pain management area, can be helpful for hiccup management as well. So those are some of the easily accessible medications. Pregabalin, gabapentin, probably second line. I would go haloperidol or chlorpromazine as the first line. Then, if you have a particular situation, patient is having hiccup because your gastric emptying is not working properly. Say, so gastric outlet obstruction. So some kind of gastric pathology or duodenal pathology, I will use a medication to empty the gastric air bubble. Or I have checked last time, simethicone is available in Sri Lanka. That's a very old medication, probably century old medication, which used to break the gastric air bubble into smoothening and pass it through the gut. So these two medications, that's two very old medications, can be used if your patient described, yes, soon after I eat and eat a lot, I get hiccups. Those patients, these two, metoclopramide or simethicone, can be helpful. If those measures do not work, what should I use? Probably what I do is, yes, my strategies did not work. Let's make the severity less, at least by weakening the diaphragmatic response, because your hiccups are so tense, the diaphragm goes to spasm. So in that setting, I usually use medications like baclofen to relax the gut, or benzodiazepines, probably something like lorazepam or clonazepam to relax the diaphragm. So those are my strategies to address the hiccups. And probably that is the end of the talk, and the floor is open for the questions. Yeah.
Thank you very much, Dr. Singh, for that marvelous, very informative and practical lecture. And you really stressed about the management of nausea, where ondansetron is just not the universal drug for nausea management. And
Yes.
yeah, and even sometimes the patients come in with gastrointestinal, GI, I mean diarrhea. Sometimes you give ondansetron when they vomit, and they ultimately end up after several few days, the patient again readmitted due to constipation,
Yes.
because yeah, that is a very very common happening in Sri Lanka. So it is really excellent, and because it's 13:10, we can entertain one question if you audience, if you have anybody. I mean, everybody has really given wonderful remarks for your lecture in the chat. Yes, there is one question. Can we use metoclopramide if patient is having vomiting with gastroesophageal?
Gastric outlet obstruction, I think. Yes, so definitely.
Yeah,
Yeah, good question.
outlet.
So very good, good question. So gastric outlet obstruction or duodenal obstruction or any of the foregut obstructions. How do I deal with that situation is, the one way to deal with that is, don't give prokinetics, because everything will come out. So that is the worry most of my registrars will have soon after the gastric outlet obstruction is noted. But my approach is, sometimes we might have when you do that declaration, oh, I'm not giving prokinetics because gastric outlet obstruction is there, that means you are not doing anything to push it through. What I do is, especially if it is an admitted patient in the hospital, I actually give a trial dose of metoclopramide while I am watching the patient. So at least I have tried a trial dose in front of my eyes, and that failed. Okay, so that patient, you will know about 20 minutes after metoclopramide dose is given, everything comes out basically from profusely. So you do a intervention trial, and you probably should warn the patient, if I'm giving this trial, and then it came out, then at least you can draw the line, unless somebody put a stent, or after putting the stent, by all means prokinetics are yes, or correction, that's yes. But before putting the stent, you probably give a cautious dose. If it works, if that obstruction is gastric outlet obstruction, I have seen many patients, gastric outlet obstructions are not necessarily anatomical obstruction, it's a physiological obstruction. Those physiological obstruction, gastric obstruction, work really well to metoclopramide. So they actually open up and start responding. That group, the prokinetics works really well. But if it is an anatomical complete obstruction, obviously with your first dose, you will know where it is going, and then you can write in the notes and side effect and explain to the patient, probably unless we correct the complete obstruction, we are not going to use prokinetics.
Yeah. Anyway, there are several questions the coming up in the chat, but what I would do is I will if you have any more questions, shall we get it shall we send those questions later to you
Yeah.
Can we email those questions if you don't mind, and then we can actually respond to them?
Yes, by all means.
Yeah.
Yeah, so I'm more
Yeah.
than happy. Obviously, the Dr. Ramdas or Dr. Andari Kumar, as well as many of the oncologists in Sri Lanka, have my email address. So anyone can send me the questions. Yeah.
Yeah. So, if you have any questions, actually send it to the SLMA Palliative Care Task Force email, and then we will forward it to Dr. Kondasinghe, who was kindly agreed to answer your questions. So, because of the interest of time, actually, we have to wind up this session. It was a very useful, wonderful, very informative session. Dr. Kondasinghe, in the future also, we would like to invite you in the same forum, as well as in some of the teaching training activities that we are planning to do in the future in establishment and in palliative care services in Sri Lanka. Thank you very much.
Thank you very much for inviting, and it's a big honor and my payback to Sri Lanka.
Thank you very much, Sampath. We all were listening to your lecture from the palliative unit in CIU.
Thank you very much.
It was really informative and really, really excellent lecture. Thank you so much for sharing the knowledge with us, Shari.
No problem, Dr. Sushari. Good to talk to you all.